Recently, I did an education with the staff. I had shown a few videos of patients with, I'd call them so-called hidden disabilities, right? Historically, people, when they visualize disabilities, they oftentimes can understand. But I really appreciated this young woman who had an ostomies testimony that just because I'm not in a wheelchair doesn't mean I don't have a disability and other particular needs. I know the ADA considers diabetes, for example, as a disability. So we've got the challenge of making sure that folks from the front door all the way through the back office understand that disabilities come in a variety of types, both that you can visualize and not visualize, and that physical disabilities have different challenges than intellectual disabilities. It's our job to make sure that we're aware of that, that we have, respect for the patient, the caregiver, the support person. Informed consent's important, language is important, access is important. So I think we're making a really good effort to do that uh, from the senior staff all the way through the exam room. Stacy, you can probably speak to that more.
So, and I think that one of the most important parts when you're caring for someone that has a disability, whether it's invisible or not, is not to see that disability first. They're there for care, and we need to focus on the reason that they're there for care, and then sort of the disability as a second piece of things. Because one of the biggest complaints that folks with disabilities have is that's all that people see. They see my wheelchair, or they see my white cane, or they see my ostomy, those sorts of things. And it's all super important, but it's not the primary thing that we need to see.
When you're seeing someone with a disability, and to Stacy's point, right, a lot of folks are sexually active, and we need to see the whole person. So a few of those steps are: number one is to assume competence. We want to give the person as much autonomy as possible, and that starts at the front desk, right?
Mhm.
They'll communicate to the provider, to the back office. If there's maybe a guardian or conservatorship, which is the least autonomous situation. But a lot of times we see quite a few folks with disabilities in several of our offices, like Uniontown, Newcastle. I'm not sure what population you had in Indiana. So there is a process for that. And that is despite the caregiver or support person to assume competence, right? We want to speak directly to that person, directly to that patient, and give them the autonomy and the respect that they deserve. Second, we want to make sure our conversation's accessible. So we don't want to use a lot of confusing jargon. We want to keep our language simple, simple words explaining things like this is, pap smear. We don't need to say cervical cancer screening. I'm going to use a flimsy, soft brush, explaining things, the tools in a way that isn't harmful and scary, because we know that, to the third point, a lot of folks, particularly with intellectual disabilities, they take issue with personal space a little more than if you don't have an intellectual disability. Oftentimes, even when I was practicing, you would have folks that might respond in a really harsh, could even seem aggressive way. So it's really important to kind of be at eye level, not to rush. Um, and asking that patient, which is point number 4, if you can speak to the caregiver, right? There's varying levels of confidence saying, would you like to be in the room alone? Would you like your caregiver in the room? Or do you understand? Do you mind if I ask your caregiver if they have anything to add? So those are 4 really important pieces that we've reviewed.
So this is where I have to include a little bit of personal information. So my daughter is blind. And it is generally assumed across the board when we seek healthcare that she is intellectually limited, and she's not. She just goes about things in a different way. So I think that really plays into the part of being a provider too. That just because something typically works for a patient with that is not does not have a disability, that's not going to work for everyone. You have to be creative, you have to be open, and the thing is the assumptions. That's the whole problem. Never assume a patient is limited just because they have a difference. I think especially women of color have difficulty accessing care to begin with. And then if you add a disability on top of that, it's just another obstacle that they have to overcome. And I think we're really good at Adagio that we can help them overcome that obstacle by providing the care that we do. We're inclusive.
There's no doubt that minorities suffer conscious and unconscious bias. There's no doubt, despite what medical providers say, because it's statistically proven, that they get disparate care. What can we do about that? Keep talking about it, keep having these conversations and, champion from the top down to do better. That's a start.
Good afternoon. My name is Christy Troutman, and I'm Executive Director of FISA Foundation and Chair of Adagio Health's Advisory Council. I'm a white woman. I have short salt and pepper hair, and I'm wearing a teal blazer today. I'm working in my home office, and so you can see some bookcases and art in the background. I'm so proud to be serving as your guest MC for Adagio Health's Better Health Outcomes speaker series today. The topic for today's presentation, race, health, and disability, is very important to me. FISA Foundation's mission is to champion equity, justice, safety, and inclusion for women, girls, and people with disabilities, and to combat systemic racism that impedes progress for these populations in southwestern Pennsylvania. As part of that work, we fund and partner with nonprofits across the region who are change makers, working to improve health and well-being for women, girls, and people with disabilities. There are many ways to frame and understand disability, and today we're using a broad and inclusive definition. A disability is a physical or mental impairment that substantially limits one or more major life activities. We often think of people with physical disabilities, such as people who use wheelchairs or canes, or those with sensory disabilities, people who are blind or have hearing loss. Disability also includes people with cognitive or intellectual impairments, could be from brain injuries, memory difficulties, people who are autistic, have learning disabilities, communication disabilities, mental health disabilities, or other chronic conditions like cancer, diabetes, asthma, arthritis. Disability is an extremely common form of human diversity, and most disabilities are not readily apparent. About 1 in 4 American adults has some form of disability. You probably know many people with disabilities, and perhaps you have one of these conditions yourself. During our presentation, you'll hear from 2 terrific speakers who are also focused on this work, Dr. Amy Houtrow from the University of Pittsburgh and Dr. Denise Johnson, Pennsylvania's Acting Secretary of Health and Physician General. They will speak about the barriers that many people with disabilities face while accessing healthcare. Physical barriers like getting into an exam room, up onto a table, getting weighed, reading the patient teaching materials that come with prescriptions, and some other barriers relate to attitudes and assumptions made about people with disabilities that can dramatically affect the quality of care that they receive. First, I'm pleased to introduce Dr. Amy Houtrow. Dr. Houtrow is a professor of pediatric physical medicine and rehabilitation and is an endowed chair at the University of Pittsburgh School of Medicine, where she also serves as the vice chair for quality and vice chair of pediatric rehabilitation medicine. In 2021, she assumed the directorship of the Leadership Education in Neurodevelopmental Disabilities Program, or LEND, at the University of Pittsburgh. Dr. Houtrow serves as the Chief of Pediatric Rehabilitation Medicine and Neuropsychology at UPMC Children's Hospital of Pittsburgh. She graduated from Kalamazoo College, earned her medical degree at Michigan State University, and completed an MPH in Health Policy and Management at the University of Michigan. In 2012, she earned her PhD in Medical Sociology at the University of California in San Francisco. Dr. Houtrow's research has focused on healthcare access and outcomes for children and youth with disabilities and special emphasis on health equity. Her work has repeatedly garnered national media attention and informed public health policy. In 2018, she was elected into the National Academy of Medicine. With that, I'll turn it over to you, Dr. Hautrow.
Well, thank you. It is lovely to be here. And as you all heard, my name is Amy Hautrow, and I'm a pediatric rehabilitation medicine doctor by training, which means my clinical practice is totally dedicated to helping children with disabilities have optimal health function and well-being. And I also research health equity for children with disabilities. I am a person with childhood onset disabilities as well. And I am sitting here wearing brown glasses. I have brown hair and a jacket that's dark red. And behind me, there are animal pictures on the wall and a couch. And I'll be sharing some information about healthcare discrimination for children with disabilities who are multiply marginalized by racial oppression and discrimination. Very briefly, I do have some disclosures. In the past couple of years, I've had a lot of grant funding from various organizations and then have taken speaker honoraria from a number of universities. And another disclosure, I love Mr. Rogers. I grew up on him, and as a Pittsburgher, how could we not bring up something from Mr. Rogers' Neighborhood? And I want us to hold on to this quote. So knowing that we can be loved exactly as we are gives us all the best opportunity for growing into the healthiest of people. What a great message. And I take from this quote guidance for us as community members, as healthcare providers, as researchers, as advocates, to really be anti-racist and anti-ableism in our work for children with disabilities who are coming from oppressed racial identities. I'm often going to use the term minoritized. You may also hear me say discriminated against, oppressed, marginalized. And just to give you a little hint about how I think about disability language, you may hear me say both identity first language, disabled child, or person first language, child with a disability. I personally come from an academic world which uses person first language. I also come from a world as a person with disabilities focused on disability justice and firmly hold on to the idea that disability as an identity is an important part of who I am and is for many people who have disabilities. So one of the things that we know about racial discrimination is that's often tied to class discrimination or classism. So minoritized race is highly associated with living in poverty. And this is just a graph of the last 20 years. Over the bottom, you see the years and the percentage of children who are living in poverty. This is all children. I want you to note that during the Great Recession, there was an uptick. There's been a general downtick and then an uptick again at the beginning of the pandemic. This is the line, though, for white children. That's about 10% of all children who are white live in poverty. Asian children, Hispanic children, and Black children who are almost 3 times as likely to live in poverty compared to white children. And this is important because I also want us to think about our work as anti-racist and anti-ableist as also needing to be anti-classist, because these things all interrelate. Just for children in general, we know that the presence of having a disability tracks by income. So this is the line here of the average number. 11% of children have disabilities related to their health conditions, that they have activity limitations. I've taken this data from the National Survey of Children's Health, but you can see by different income bracket, the lightest green are the children living in poverty, and the darkest green are the children living well above the federal poverty level. There is a stepwise relationship. And as many of you are already aware, poverty is both a cause and a consequence of disability. And we see this right here for children. We also see differences or disparities in the presence of disability by minoritized race, such that, again, this is that average all children, 11%. Children who are minoritized Black are much more commonly disabled than other children. And we saw that relationship between income and race, race and disability and poverty. So these things are a confluence of factors that really impact how children are able to receive care. And to benefit from high quality care, you got to be able to access it. One of the key components of pediatric healthcare, a key metric of a standard of care, is family-centered care. And what that means for people is that the doctor or other healthcare provider spends enough time, listens carefully, is sensitive to your family values and customs. I want you to hold on to that idea, family values and customs. They give you the needed information and they make you feel like a partner. Well, how do we do as a world of pediatric healthcare? By minoritized race, not so great. So 90% of families who are white report that they get family-centered care. On average, it's about 85%. And it's because minoritized Black and Hispanic children are much less likely to receive family-centered care. And the reason I asked you to think about understanding your family's values and customs is because we know that we have a workforce issue such that the people providing care in healthcare don't look like the people who are receiving care. And while we can work very hard to be culturally humble, the goal of complete cultural competence, it can't be met until we have a much more representative workforce. We, though, as each individual provider, need to emphasize our role in addressing any implicit biases that we might have. So let's look at being frustrated at getting care. So this is again by minoritized race. And luckily, just under 20% of families report being frustrated. So it's not everyone, but that number feels too high to me. But we also see that the people who are least likely to be frustrated are white families, and minoritized Hispanic families are the most likely to be frustrated getting care. So I want to talk about a systems level perspective just for a moment and give you a quick example. So let's say you are a pediatric office and the cost of labor has gone up, rent for your office has gone up, and the practice manager is desperately trying to figure out how can they bring more dollars in. The nurse practitioners, the physician assistants, and the doctors are all seeing kids fast, maybe faster than they think is appropriate to actually provide family-centered care. So asking them to see more just doesn't seem logical. So then as a practice manager, you look at the reimbursement that you get from various insurance companies. So Medicaid reimburses much less on the billed dollar than most private insurers. So you think as the practice manager, I know what we need to do. We need to limit the number of children we see who have Medicaid. Well, guess who has Medicaid? Children who are living in or near poverty, children with disabilities, and children who are from minoritized racial backgrounds. So then once you change who can get an appointment, by nature of doing that, you are discriminating as a practice against children who are minoritized and potentially against all the children who need the care the most. So children with disabilities, for example. No one in the practice was saying, I want to develop a racist practice. I don't want to discriminate, is what doctors say, what pediatricians believe. But the way things are often set up bakes in discrimination. So one of the things we need to do is examine those forces that are baked in, that are across the system, within the system. So let's take a look at some other data. So this is an example of who reports not having trouble getting a specialist to see them. So children with disabilities really often need to get specialist care. And as you can see, most people, most families, 75% of them say they're not having difficulty doing this. Obviously, we've got some work to do for the 25% that are. But what you can also see is that families who are white are much more likely to say, yeah, not a problem for me. Whereas families from minoritized Black backgrounds are much more commonly saying it is hard for them. So let's use an example again, just to illustrate this kind of on a systems level. So imagine a child is getting specialist care but it was delayed because it was very hard to get it. And that specialist says, well, for your child's disability, I really think it's important that your child gets routine physical and occupational therapy. They make a referral and write the prescription. You go to the initial appointments for physical therapy and occupational therapy. And the recommendation is that your child does that once a week. But the only places where there's a therapist who can get them in the schedule is in the location that's in the suburbs. So not one that's on a bus line, not one that's easy for you to get to because you live in the city. But because there's been such a delay, it's been hard and you've been frustrated getting care and you've had difficulty getting specialist care, you say, yes, we will take the appointments that are available. I want my child to get more functionally capable. Well, even though you don't have access routinely to an automobile that's reliable, even though it's not on the bus line, you do your best. But it turns out that you can't always get there on time. It turns out that sometimes you miss those appointments. But if that therapy location has rules about attendance, oh, if you come more than 15 minutes late, we won't see you. Oh, if you no-show, that's a strike against you. And we have a 3 strikes you're out policy, meaning that if you're late 3 times or you don't show up 3 times, we're not seeing your kid anymore. Well, what that does is set up that policy for efficiency for that practice, right? They want to fill those spots. And if you're not going to be there for them to be filled, then they want to give other children the opportunity to have those spots. But it also embeds this classist and racist way of setting up the practice so that children who have disabilities coming from backgrounds for which they don't have easy access to transportation or don't live in that suburban environment, for example, that they have less access. And so it's another way that children are and their families from these backgrounds are being oppressed. This is oppression inside the healthcare space. And there is great justification why these policies exist when volume matters. But each of the times these things happen, we really need to think about the consequence to health equity, which is why I'm giving you these imaginary examples. So in general, what's happening is the system of care for children and youth with special healthcare needs, some of whom have disabilities, isn't great. Less than 15% of these children have a system of care that works for them. So what that means is that their parents feel like a partner in care, that they get care within a primary care medical home, that they've had preventative dental and medical visits, that their insurance meets their needs, and their health care that they needed was received, and also that they weren't frustrated trying to get it. For older children, it also includes transition services. Overall, we're doing, I don't know how to say it other than this, a craptastic job of delivering a good system of care for children with special healthcare needs. But it is much worse for Hispanic families. And like all of the graphs I showed you, more children who are white are receiving this care than other children. So what do? We have work to do, because what we don't want is to perpetuate oppression and discrimination and marginalization within healthcare. But that means not only working for our own selves and addressing our biases, it is that we have a system that needs to change. And so what I am calling for, and I am not the inventor of these recommendations, if you'd like to seek them out, here is the webpage to do so, is that we need to routinely and systematically apply equity principles. We have to have this human rights perspective in everything we do. We need to understand the consequences of policies and practices. And then we also really need to strengthen and extend public health functions. And I know this has been incredibly challenging as our public health system has shown how strained it is and how much it's struggling to do public health in the face of the pandemic. But what we need as a society is to create the conditions for good health. So that means addressing upstream factors like poverty and discrimination that keep children from being healthy. And then once they need the healthcare system needs to respond in an equitable fashion by implementing equitable principles, whether that's in healthcare financing, I personally am a believer in the federalization of Medicaid for all children. We have Medicare for older adults. We could do something like this on the federal level so that all kids have equal access to care. There are things we can be doing as a society, continuing to work towards reducing poverty, and also while making sure that access to needed healthcare is there for people who are poor, who are often also racially marginalized and oppressed. In addition, we really need to advocate that we are responding effectively and efficiently to what are the major preventable causes of poor health. So I'm just going to give you a quick example, right? We know that children who are Black are more likely to live near highways, high pollution areas. They are also more likely then to have asthma that is hard to control. There are things that we can do. Housing as health is a way that we can prevent poor health outcomes. We need to emphasize those prevention strategies, undo the political and social systems like redlining or lack of access to accessible low-income housing for people with disabilities that set them up for poor health outcome. And we really need to be monitoring and advocating and taking action to address all of these areas around health equity and think first and foremost about the human rights implication of what our policies are in any sector that affects health. So yes, inside the House of Medicine, but not just inside the House of Medicine, just as I mentioned in the housing sector, in the criminal justice sector, and the education sector, equity should be at the forefront of our minds. And I think many of you are familiar with many wonderful quotes from Martin Luther King Jr., but I'm going to leave you with this one. All the forms of inequality, injustice in healthcare is the most shocking and inhumane. And to me, this is a call to action. We can do better. We have to work on ourselves on an individual level to address our implicit biases. But more importantly, we have to break down the systematic and systemic barriers to equity to really optimize health and well-being and functioning for children with disabilities, and especially those children with disabilities from marginalized identities. Thank you very much for allowing me to speak with you today, and I hope you have a wonderful rest of your afternoon.
Thank you so much, Dr. Hautrow. That was excellent. Such important points. Our next presenter is Dr. Denise Johnson, Pennsylvania's Acting Secretary of Health and Physician General. Prior to serving in this role, Dr. Johnson was most recently the Chief Medical Officer at Meadville Medical Center. Before joining the Meadville Medical Center leadership team in 2008, Dr. Johnson spent 13 years in private practice in Meadville. She is board certified in obstetrics and gynecology by the American Board of Obstetricians and Gynecologists and is a fellow of the American College of Healthcare Executives. She serves on the Governor's Commission for Women. Dr. Johnson has been involved in various community and regional groups focusing on diversity and inclusion and on the needs of women, and is the former board chair of the Meadville Area Free Clinic. She is past chair of the board of directors at the Pennsylvania Coalition Against Rape and a past board member at Adagio Health. Dr. Johnson received her medical degree at Georgetown University School of Medicine and completed her residency at Vanderbilt University Medical Center. Here is Dr. Denise Johnson.
Well, good afternoon, everyone. I am Dr. Denise Johnson. I am serving as the Acting Secretary of Health and Physician General at the Pennsylvania Department of Health. Glad to be with you all today. I am a Black woman who is recording from my home office. I'm sitting at my desk here and I have a lovely landscape picture behind me, as well as a picture from Meadville in northwestern Pennsylvania, where I'm from. So I will get started today. My talk is titled Race, Disability, and Access, and talking about what we have here in the Commonwealth. So my next slide defines health equity, and it's a graphic that many of you have seen. There are three individuals in the library. One is tall and able to reach the high books. The other is using a ladder to get to the high books, and the other is in a wheelchair and is not able to reach the high books. So health equity is defined as being achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. Ideally, we would just level the playing field so everyone can have access. But because there are varied access for individuals, we really need to make sure that each individual gets what they need to be able to access. And that need might be different based on the different individuals. Next, I'm going to talk about the Office of Health Equity at the Pennsylvania Department of Health. The mission of that office is really to provide leadership and to promote public awareness of health disparities. We also advocate for programs that eliminate disparities and collaborate with stakeholders to achieve measurable and sustainable improvement in the health status of underrepresented populations. So some of the activities I'm going to talk about today are first, the PA Interagency Health Equity Team. We call it PHET. Also, the COVID-19 Health Equity Action Team, which is now called HEAT, H-E-A-T. The Regional Health Equity Action Team, Culturally and Linguistically Appropriate Services, and the Community Health Organizer Programs. So first of all, the PA, or Pennsylvania Interagency Health Equity Team, is a group of multiple agencies across the Commonwealth that work together to address health equity issues through strategic partnerships and idea sharing. So this is the Department of Health, but we also have Department of Transportation, Labor and Industry, many, many different agencies across the Commonwealth. I also want to mention the COVID-19 Health Equity Action Team. It was originally the COVID-19 Health Equity Response Team, but it addresses the needs of certain populations. We identified populations that might be underrepresented or need a special focus during the COVID-19 pandemic. So these were individuals over the age of 65, racial and ethnic minorities, LGBTQ individuals, pregnant individuals or parents of very young children, rural Pennsylvanians, Pennsylvanians with disabilities, survivors of interpersonal violence, individuals living with mental health or substance use disorders, economically challenged individuals, or employees who are or underinsured, and immigrants and refugees, among others. So our Regional Health Equity Action Team, or HEAT, is actually separated into regions. So there's the Northwest, North Central, Northeast, Southwest, South Central, and Southeast. These groups focus on vulnerable populations, but the goal is to improve the health equity access across the Commonwealth. They really take a hyper-local approach, and they're led by a hub, that's a committee, but it also involves faith-based organizations, um, individuals, there are academic institutions, um, other healthcare organizations, all working together and collaborating to address health inequities within their regions. One of the focuses of these regional teams has been to really look at areas that have been historically redlined that are called health equity zones. These health equity zones ex experience more negative outcomes, have individuals that may have disparate outcomes in all health parameters, and they focus on these areas for improvement. Also want to mention the cultural and linguistically appropriate services. The department and our Office of Health Equity has created a toolkit to make sure that services are provided in an equitable, understandable way, as well as being respectful. We want to make sure that individuals are getting quality of care and that we are responsive to their diverse cultural needs, as well as health beliefs and practices in their preferred language. And so the department has instituted this toolkit, but also is requiring this language in our contracting. So as we contract with other organizations to do work for the Commonwealth, we want to make sure that they are providing culturally and linguistically appropriate services. The last initiative I want to highlight is our Community Health Organizer program. And this is relatively new, but really an exciting initiative for us. So first, I want to talk about the difference between a community health organizer and a community health worker. Community health workers are downstream drivers of disparities and health equity. They are boots on the ground. So they work directly with local communities to promote and to provide services. They can be physical health or behavioral health. The community health organizer is an upstream driver of these disparities. So they support larger areas on the county level. Sometimes it's more than one county, and they have a health equity focus. They also address the social determinants of health, but they're involved in policies and procedures that impact a larger population. Right now, we have 35 community health organizers working across Pennsylvania, and they're responsible for providing educational resources and training around COVID-19 prevention and immunization. But they build relationships and partnerships with community leaders. So these may be the faith-based groups, academic institutions, individuals, other nonprofits. And they also have organizing activities to collaborate and to build support for the infrastructure to provide sustainable health equity interventions and mitigation strategies in the areas that they're responsible for. I'm going to switch a little bit now and talk about health equity and people with disabilities. So the community of individuals with disabilities is quite diverse in race, diverse in abilities, and diverse in experiences and needs. People with disabilities in Pennsylvania, the 2020 American Community Survey 5-year estimates show that over 1.7 million Pennsylvania residents, or 14%, are living with a disability. And there are many types of disabilities. 7.3% were estimated as having an ambulatory disability, 6.4% an independent living difficulty, 5.9% cognitive, 3.8% hearing, 2.8% self-care difficulties, and 2.4% vision difficulties. And it's important to note that an individual may experience more than one of these disabilities. We also know that disability status by race and type are prevalent within in Pennsylvania, meaning that disabilities are more prevalent in individuals with in the racial minority communities. For all races that are non-white, the disabilities are higher. And these can be disabilities relating to ambulatory difficulty or cognitive difficulty. All are higher in the non-white population. We also know that individuals with disabilities also experience other health disparities and are more likely to have obesity or smoking or diabetes and heart disease, which compounds the disparities in health outcomes. Just loading up this other slide here. With also, the National Disability Institute produced a report on financial inequality. And it was noted that 1/3 of adults with disabilities had difficulty paying for medical bills in the past 12 months. And that's compared to 14% of adults without a disability. That disparity and that level is higher for African Americans, where 33% with disabilities had difficulty paying for bills, compared to 20% without disabilities. We also know that adults with disabilities were 3 times more likely not to get the medical care that they needed in the last 12 months because of costs, more than their non-disabled peers. We know food security. Working age adults with disabilities are 4 times more likely to live with significant or low or very low food security than adults without a disability. And that can mean a reduction in food intake, skipping meals because of the household lacking money, a reduction in the quality or variety, or even desirability of the food intake at mealtime. I'm going to talk a little bit about the challenges that were experienced during the COVID-19 pandemic. We know that a person's risk for severe illness with COVID-19 really increased with the number of underlying medical conditions that they had. We know that people were very at risk of being very sick or dying with COVID-19 because of where they lived or worked or because they couldn't get health care. And that included many people from racial and ethnic minority groups and people with disabilities. People with disabilities were more likely than those without disabilities to have chronic health conditions or lived in a shared or congregate setting and face more barriers in accessing healthcare. And all of those factors were shown to be and give you an increased risk to have severe outcomes with COVID-19. In July 2020, the department's Health Equity Response Team, which is now called HEAT, identified some strategies to mitigate those challenges experienced by Pennsylvanians with disabilities. In April 2022, the Administration for Community Living's National Institute on Disability published a new report entitled The Impact of COVID-19 Pandemic on People with Disabilities, and it highlighted substantial delays and the required pivoting experienced by the disability community during the pandemic. And some of the topics highlighted are this: mental health factors. Individuals with chronic illness and disability experience more mental health disorders and at higher rates than those without disabilities. And that disparity got magnified during the pandemic. Education, COVID-19 implications created disruptions in schools for children with disabilities. Employment, people with disabilities, especially in rural areas, were very vulnerable to COVID-19 recession because they're less likely to have emergency saving funds and didn't have access to paid leave or able to work from home. Some of the access to care challenges. In 2020, the department had held 8 focus groups to inform our state health assessment. And these focus group respondents identified access to healthcare challenges to include lack of accessible providers in rural and urban areas due to transportation, provider shortages, merging of hospitals. There were insurance barriers preventing access, stress associated with trying to access various types of care at multiple locations, and a lack of awareness about services and resources that were available. Sometimes the health information was not communicated effectively, especially to those for whom English was not their first language. Some of the challenges and lessons learned during COVID. In the Department of Health saw challenges to healthcare access and outcomes that included congregate housing, really difficult to find permanent home or community-based housing for all individuals due to lack of affordable housing even before the pandemic. staffing issues, which are still ongoing. Many personal care boarding homes lack initial medical staffing to conduct universal testing. And there was missed preventative healthcare visits and vaccination. Normal hospital procedures were paused during the COVID-19 response efforts, and that delayed preventative healthcare visits and vaccinations. So the Disability Integration Task Force was created under the Department of Human Services to look at issues faced by the disability community and to look for ways to create solutions that would be integrated into existing services. Some of the issues that were raised were access to adequate supplies of personal protective equipment, instances where emergency communications were not inclusive of individuals with disabilities and unavailable in multiple formats. Staffing shortage, especially in long-term care facilities, transportation access for people with critical needs, direct support persons, and other home health aides weren't able to safely care for consumers in their homes due to staffing shortages, as well as inadequate supplies of personal protective equipment. Seniors and people with disabilities living alone in isolation were at risk for overall decline due to limited contact with family and friends and access to services and food, especially in rural areas. And then the digital divide and digital deserts that isolated people even more. There are also issues with not being able to have a support person to accompany consumers when they had medical appointments. And then long-term care facilities restricted visitation, which put residents at risk for abuse and inability to communicate with their family and other providers. So, what are some of the actions and interventions that we employed? Well, the Department of Health approach to addressing the challenges faced with the disability community and testing and vaccination and treatment, here are a couple of things that we did. We developed recommendations that leverage stakeholders to assist with staffing shortages. We established the Disability Subcommittee to address some of those issues that arose. And we funded both the ARC of PA and the Institute for Disability at Temple University to address needs in the community. And we were active participants in the Department of Human Services Disability Integration Task Force. One of our good successes notes that about 1.5 million people in Pennsylvania are deaf or hard of hearing, and Pennsylvania provided ASL interpreters, as well as captioning in English and Spanish for the COVID-19 briefings. We coordinated the services for the briefings with the Office of Deaf and Hard of Hearing from Labor and Industry and the Department of General Services, as well as Commonwealth Media Services and the Pennsylvania Emergency Management Agency. The National Association for the Deaf recognized Pennsylvania for its handling of the interpreter access during the government briefings. In spring 2021, then Secretary of Health, Allison Beam, amended the order for vaccine providers to make sure that they were working with the local area agencies on aging and the Medicaid program for vaccine scheduling appointments. And that opened the door for a lot of the collaborations that the Department of Health had to make sure that we were vaccinated individuals that could not leave their homes. So we worked with the Department of Human Services to ensure that Medicaid enrollees were contacted to get their vaccines and their boosters. We partnered with the Department of Aging to make sure that they were operating vaccination programs for homebound residents and for others who needed to have that service. We operated a direct hotline to connect homebound residents with their local area agency on aging and a vaccine provider. And we also coordinated our county and municipal health departments to ensure that there was local programming to vaccinate homebound residents within those jurisdictions. So some of the outcomes and experiences. The ARC of Pennsylvania received funding to investigate and educate and report on problems that individuals with disabilities in Pennsylvania had accessing appropriate information and help during the pandemic. The project was designed to answer the following questions. To what extent have we used a disability inclusive approach to combat COVID-19? And to what extent will we use that approach to prepare for future emergencies? And this project was in part funded under a grant with the Pennsylvania Department of Health. So the project included surveys and meetings to collect information and responses from people with disabilities. And these responses were collected and organized into list of barriers or obstacles that made it more difficult to access the benefit of healthcare services. And they were these barriers were grouped based on social determinants of health. And in order to understand the intersectionality of disability and racial and ethnic diversity, the sample included outreach from populations all across Pennsylvania. We wanted to make sure that we got to underserved populations, Asian, Hispanic, um, African American, Indigenous, LGBTQIA communities, and we included 4 of the 10 most rural counties and 9 of the 10 most urban counties in Pennsylvania. One area that we noted under cultural and linguistic is that discrimination occurs in minority populations even without a pandemic. But the pandemic exacerbated these experiences. And one study found that a large percentage of multiracial and non-Hispanic adults of other races and ethnicities really worried and reported stress about the stigma of discrimination and being associated or blamed for spreading COVID-19 in comparison to white adults. So some of the strengths that were identified during the COVID-19 pandemic with a higher frequency than other areas were vaccination, local condition, communication, and technology as the pandemic progressed and we responded to some of the concerns that were noted earlier on. So the next step for us, we really are informed by a deeper understanding of how the COVID-19 barriers among Pennsylvania with disabilities played out to make sure that we inform our response going forward so that we learn lessons from the pandemic and we create sustainable improvements over the status quo. And so part of the Pennsylvania Office of Health Equity's 2022 focus on disability equity is an initiative and an opportunity for learning connected with our joint action to increase health equity for all communities, but especially in the disabled community. So I will stop there just to say that we have a focus on health equity at the Pennsylvania Department of Health. And during the pandemic, we really sought to find out where our gaps were in terms of addressing the community of individuals that are living with disabilities during the COVID-19 pandemic. And we continue to use that work to inform our work going forward to make sure that health equity for all populations is something that is a part of all of the work that we do. And so that we are not going on the back end to try to close gaps going forward, but we are proactively looking at ways to make sure that we improve health equity and fulfill the vision of the Pennsylvania Department, which is a healthy Pennsylvania for all. Well, thank you very much. It was my pleasure joining you here this afternoon.
Thank you so much, Dr. Johnson. I want to also thank Adagio Health for inviting me to serve as your guest MC today. This is the final edition of the Adagio Health Better Health Outcomes Speaker Series for 2022, but the series will return next year, hopefully with in-person opportunities to hear from great speakers on women's health and greater health equity for all. Look for more information on next year's series in the coming months. In the meantime, I'm Christy Troutman, Executive Director of FISA Foundation. Thank you so much for your support of this important series. Have a great day.